go to a GP, a record of that interaction is created. And if we can link these records together over time, then we can help build up a picture of someone's pathway through life. And I'm particularly interested in what happens prior to and during pregnancy and how this relates to later maternal and child health. So if each of these bars here represents a point of interaction with the service, so for example, a hospital admission in dark blue or a GP visit in the light blue, then these events, these are events from which we can obtain information, for example, diagnoses, procedures, or blood pressure measurements, or BMI measurements even. And that information can help us build up a data set. One of the challenges with this is that in England, we don't routinely link information from mothers to their babies, and mother's NHS number isn't recorded on the baby's record, or vice versa. But it is possible to use other information such as dates, geography, and clinical information like gestational age and birth rate, which should be the same. They should be recorded in the same way for mothers and babies, to link these data together. And this can allow us to look at how maternal factors early on can influence a baby in their early years, and then throughout their childhood and beyond. So we can also, in the same way, think about linking in siblings, which provides us with an opportunity to do sibling control analyses. So by using discordant pairs, we can try to tease out the mechanisms by which exposures are influencing outcomes. And we can also think about looking at the pregnancy period and what happens during these periods and what happens in between pregnancies, the inter-pregnancy intervals, and about how these might influence child and maternal outcomes. And then thinking more broadly, we're beginning to be able to take advantage of linking with wider determinants of health, including social and environmental exposures and educational data, which might be an exposure on the mother's record, or it might be an outcome in the child record. So each piece of information that we link in is like another piece of the jigsaw and helps us hopefully to understand how different parts of our lives fit together. And ultimately, the aim is that the government then could think in more joined up ways in terms of policies to improve outcomes. In my next few slides, I want to give some examples of the value of linked mother and baby data, if my barky dog in the background lets me. So first, it can be used to answer questions that can't be addressed using traditional approaches. So for example, evidence from randomized controlled trials suggests that early induction of labour for first-time mothers aged 35 years and older has no short-term adverse effects and might be beneficial in terms of safety. But it's difficult to power an RCT for very rare outcomes, and the trial evidence that was available wasn't able to give us a definitive answer about the risk of perinatal death. This would require tens of thousands of mothers to give us a statistical power to do this. And this is where linked administrative data really has some value. So in this study, we linked data for 77,000 mothers and found that compared with expectant management, induction of labour at 40 weeks of gestation was associated with a 66% lower risk of perinatal death. And this obviously has important implications for policy guidelines and also for women who want to make decisions about childbirth. A second example is that linked data can help us identify early indicators of need by bringing together information about the period before pregnancy with information about what happens at birth and in early childhood. This plot comes from a study of pre-pregnancy psychosocial risk factors where we used linked data for 2 million mothers in England. It shows the relationship between maternal age along the bottom and birth weight in the top plot, and unplanned admissions for injury in the second plot. And you can see that there's a strong pattern according to maternal age, and that the best outcomes are seen for mothers around the age of 30 to 35. But But we can also see variation according to whether a mother had a history of mental health conditions in the 2 years prior to her pregnancy. Here, this is the blue line, which is the lowest birth rate babies and the infants with the highest rates of unplanned injury admissions. And also for mothers who had a previous hospital admission for adversity, which includes violence, self-harm, or drug and alcohol abuse. And that's shown here with the red lines, which also have lower birth rates and higher rates of injury admissions than the other groups. So if we can routinely identify maternal risk factors prior to pregnancy, and we can do this using routinely collected hospital data, then we might have an opportunity to know which groups might benefit most from intervention and who should be targeted to reduce adverse effects for children and downstream burden on health services. A perhaps less obvious benefit of data linkage is improving the quality of administrative data. This study by colleagues of mine at ICH aimed to understand whether differences in child mortality between England and Sweden could be attributed to adverse characteristics at the time of birth. So they wanted to know whether the increased rates of mortality in infants in England were explained by, for example, babies who were born at a lower birth rate or a lower gestational age. But for the time period that they were looking at, the data wasn't particularly complete on the key risk factors that they were looking at in the baby's records. But by linking to the associated maternal record, they were able to increase the completeness of these variables. And this meant that they could increase their complete case cohort from 18% of all births in England to 75% using the mother-baby linkage. And then final example, we can use linked data not only as part of observational research, but also to supplement clinical trial follow-up. So an example of this, which I think is just brilliant, is something that was recently published by a PhD student, Max Ververden at ICH, who managed to bring together data from 7 historical trials of infant formulas, which were conducted in the 1990s, and link these to current administrative data. So the trial, the follow-up in the trials themselves was affected by attrition. This plot shows the percentage of participants who responded at the latest follow-up in each of these 7 trials. So for example, in this trial, which looked at small gestational age babies, only 6% of the original trial participants were contactable by age 17. And you can understand why this might be so low. Children move around a lot. They were involved in these trials as babies, and now trying to follow them up at age 17 would be quite difficult. But understanding these long-term outcomes is really important. So by linking the old trial data to up-to-date administrative data, they were able to increase the follow-up to over 80%. They had over 80% of participants in the original trials were linked to their GCSE examination scores at age 16. And this meant that they were able to analyse GCSE outcomes according to the original trial arm, and concluded that infant formula modifications didn't promote long-term cognitive benefits compared with the standard infant formulas. So the axis on this plot relates to the mean difference in standard deviation score, and points below the line show a worse outcome for the treatment arm. So clearly there are huge benefits to being able to use linked data, but there are also challenges relating both to privacy and confidentiality, but also to quality. So firstly, access to administrative data is often extremely time consuming, and this is even more of a challenge when we're requesting that identifiers are released from one data holder to another to allow linkage to be performed. So this generally means that linkage is conducted by some sort of trusted third party with minimal input from the data users or the researchers. And this can be problematic because quality of the unstructured data, as I've already mentioned, isn't always optimal. And that means that linkage with unique identifiers isn't always possible. Unique identifiers are often incomplete or not available, and particularly when linking across different sectors or government departments. And this means that we have to think carefully about the types of linkage methods that we're using, depending on what sorts of identifiers we have available. So concerns about privacy and confidentiality and issues around data quality can lead to linkage errors, which is where we fail to link records that belong to the same individual. This results in false matches, where we fail to link records that belong to the same people would be a mismatch, and where we link together different records that should have belonged to different people, and that would be a false match. And even small amounts of these linkage errors can lead to substantial bias in results. So this means we need to think carefully about ways to handle these errors or uncertainty in the linkage in the analysis of linked data. So how is linkage done? The most straightforward approach is to use a deterministic or rules-based linkage. So this algorithm is the one that was used until quite recently to link hospital records within hospital episode statistics, which is the national data set of routinely collected hospital records in England. So the first set of identifiers that are looked at in this deterministic linkage rule are sex, date of birth, and NHS number. And then if records don't match on that, they're checked to see if they match on sex, date of birth, postcode, and a local patient identifier or hospital number. And then finally, just sex, date of birth, and postcode. Now, this is quite a conservative algorithm because it's unlikely that many different people would share the same set of identifiers, except perhaps for same-sex twins who might have the same sex, date of birth, and postcode. But this minimization of false matches is traded off against mismatches. And you can see that because sex, date of birth, sex and date of birth are included in all three of these steps, that any errors on sex or date of birth or missing data would mean that a record that was submitted to HES and checked against this linkage algorithm would be given a new HES ID rather than being linked to an existing record in HES. So to address some of these issues, probabilistic linkage was proposed, which generates a match rate or a score to represent the likelihood that two records belong to the same individual, given the agreement of identifiers on those two records or any disagreement. The way the match rate is calculated means that agreement on something that's quite discriminative, like NHS number, contributes a large amount to the match rate. Agreement on something like sex, which is more likely to agree by chance, still contributes positively, but a smaller value. And disagreement on a particular identifier, say date of birth, would contribute a penalty to the overall match rate. So for linkage of mothers and babies, we had an additional problem, which is that we don't have access to identifiers. And even if we did, it wouldn't necessarily be helpful because a mother's NHS number isn't recorded on the baby's record and isn't the same as a baby's NHS number. However, we know that in HES, hospital episode statistics, along with the main record for an admission, if the admission is associated with a delivery or with a birth, then there is an additional set of fields known as the baby tail, which includes another 20 or so variables, including things like birth weight, maternal age, gestational age, etc. So by using combination of deterministic and probabilistic linkage, we were able to use this information to find the same mother and baby pairs in HES. So this plot shows the probabilistic match rate associated with each of these variables. And you can see that something like sex isn't very discriminative when it agrees with low weights here, but then something like estimated delivery date here, disagreement on that would contribute a large penalty to the overall match rate. So it cleverly takes into account how discriminative a particular variable is, but also how likely it is that that variable has been recorded incorrectly or not. Okay, so I mentioned that there's a trade-off between different types of errors, false matches and mismatches. And whether we're thinking about a probabilistic linkage approach or a deterministic linkage approach, we have to choose some sort of cutoff to decide where the records we accept are matches or whether we discard them as being non-matches. So we want to separate out these two groups of record pairs, but we don't know where the optimal cutoff is. We don't know which records really are matches or non-matches, because that's what we're trying to identify through the linkage process. So if we have a relatively high threshold, then this means that our linkage is more, it has higher positive predictive value. We're more certain that the matches that the links that we've made really are true matches, but we accept that we will have missed some of the true matches as well. And as we lower that threshold, we increase the sensitivity, we capture more of the true matches, but we trade this off against including some false matches. So it's quite important to think about how these different types of errors might influence our analysis or might lead to bias. And this can happen in different ways. So starting with mismatches, where we fail to identify a link, then the first problem is that this causes missing data. If we're not able to make a link, we haven't been able to bring across the information that we were hoping to obtain for an individual. So the potential bias will therefore be determined by whether that missingness or the linkage error is at random, or whether the linkage errors are concentrated in a particular subgroup. And the way that this will manifest in terms of bias depends on how we handle that missing data, as in any other study. So for example, only including linked records in an analysis would be analogous to a complete case analysis and would result at the very least in a reduction in statistical power. Secondly, mismatches can lead to misclassification or measurement error. So for example, if we were linking to a mortality record, but we missed the link, we would misclassify an individual who has died as having survived. And then thirdly, if we're linking to, for example, a disease registry in order to define our population of interest, the records that we want to analyse, we might erroneously exclude or include someone who we were unable to link. And then finally, we can end up splitting one person's records into many different records. So in the context of hospital records, mismatches or splitting could result in us thinking that we were looking at one admission for a lot of people rather than lots of admissions for the same person over time. So this plot comes from Linkage is a Swiss national cohort study with mortality records. And the blue line here is the mortality rate that was estimated from the linked data. When the authors looked at external reference data or national statistics for this particular group in terms of mortality, they could see that their linkage had missed a lot of the links that should have been made with mortality records. Now, if this was consistent over time, then this might not have been too much of a problem. If they were looking at, they would have underestimated mortality rates, but trends might have been able to be analysed still. But we can see that this isn't the case in this particular example, because the amount by which the mortality rate was underestimated changes and wobbles around a little bit. So in the year 2001, it was much better. It was a census year, but then in the year 2000, you can see there's a big gap there. So comparing our linked data with an external gold standard or a reference can help us identify which groups might be most affected by errors. In this case, the group was females aged 85 and over, but also time. And we can see that we might need to think carefully about how we interpret trends in linked data. we expect all of our records to link, as is the case with mothers and babies, we expect each baby to have a mother in the data, then comparing the characteristics of linked and unlinked data is a useful thing to do. So this table comes from, again, linkage of mothers and babies, this time in Australian hospital records. The first column corresponds to matched records and the second two columns to unmatched infants and unmatched mothers. And by comparing the characteristics in these different groups, you can see that the outcomes that they were interested in, stillbirth and preterm birth, were much lower in the matched groups. So the unmatched records were more likely to be stillbirth or preterm birth. So there's something about the data quality associated with these records that made them more difficult to link. But they could also see that Australian-born mothers and births in private hospitals were less likely to link. So despite having 99% of records linked overall, there are still these important differences, and it becomes difficult to tease out what the mechanisms here are. So for example, these things might be unrelated, but it might be that births in private hospitals were more likely to be for older women or women who had a greater number of risk factors and who therefore were more likely to experience these outcomes. So it might not have been something to do with the stillbirth or the preterm birth records necessarily, but the types of mothers who attended private hospitals, which might have different data quality systems. So it gets quite complicated to think about all of these things, but being able to compare the characteristics like this helps us to identify potential sources of bias. So thinking again about how errors are distributed, this plot shows the readmission rate you would estimate based on linked hospital records if we had missed matches in all groups. So this is an example of splitting where the same person's records aren't linked over time. And although in this example we've underestimated the readmission rate in all groups, the relative differences between groups are retained. But if errors aren't distributed randomly, then the relationships between the readmission rates and ethnic group get completely distorted. And there are lots of examples in the literature where the success of the linkage varies according to things like ethnic group. So that was mismatches. And now in terms of false matches, these can have similar consequences: misclassification or measurement error, or erroneous inclusion or exclusion, but the other way around. And the opposite problem to splitting, so where we think that records for multiple people belong to the same person. And false matches and mismatches don't occur in isolation, but as I've shown, are a trade-off. So this table comes from a study looking at ethnicity and mortality in the US. And the original linkage found that there was no association between Hispanic ethnicity and mortality, which the authors were surprised about. It hadn't been what they had been expected. But they hypothesized that perhaps Hispanic names were more difficult or more complex and therefore more difficult to link. So when they relaxed their linkage criteria, the hazard ratio was significant in the direction that they had expected. So Hispanics appeared to have higher mortality rates. But then conversely, when they tightened the linkage criteria and had a more conservative approach, the hazard ratio was significant in the opposite direction. So this just demonstrates that linkage errors can really have an important impact on the inferences that we draw from linked data. So what can we do about this problem? There are a number of ways we can think about evaluating linkage quality. So first we can look to gold standard data. So this might be a subset of the data for which high quality identifiers are available, or that we can do some sort of additional tracing on. Or it might be in the form of positive or negative controls, where we know that a subset of our records definitely should link or definitely shouldn't link. And secondly, we can compare the characteristics of the linked and unlinked data. as we saw with the mother and the baby linkage. Or if we don't expect all of the records to link, then we can focus on looking at the quality of identifier recording for different subgroups. So I'll give an example of that in a minute. And then finally, we can use quality control checks to identify the types of groups who are most likely to be affected by linkage error. So thinking about positive and negative controls, the first example here was where we linked infection surveillance records from Public Health England with neonatal admission records from the NNRD, the National Neonatal Research Database. So we didn't know before we started how many neonatal records should link to an infection record. And comparing the characteristics wouldn't have been helpful here because neonates that had an infection would be systematically different from those who didn't. But for a subset of the neonatal records, there was a clinical recording in the neonatal record of infection. So we knew that we could use that group, that subset, as a group of positive controls who should definitely link to their laboratory record. So that is one way that we use to try and estimate rates of linkage errors. And the second study looked at linking pregnancy records with birth registrations. And we knew in this setting that pregnancies with abortive outcomes shouldn't have linked to a birth registration. So where we had made a link, we knew that that was a false match. So this was an approach that we used to estimate false match rates. Comparisons with external reference data. One of the things that we did with our mother-baby linkage was look at how the characteristics of the linked cohort in the dark blue here matched those of national birth statistics from the ONS. And this showed that we were less likely to link some of the more extreme gestational ages and lower birth rates, and also some of the younger records from younger mothers. So although we managed to link the vast majority of our records, the ones that we had missed were more likely to be these more vulnerable or harder to reach groups. And then this study looked at the quality of data before the linkage was actually done, and saw that young men were less likely to have NHS numbers recorded in their records. So this is a useful thing to do because it tells us, before we even start the linkage, whether records from some groups are less likely to link, more likely to be prone to linkage error, and whether we can tailor our linkage strategy differently to those groups. And then finally, we can look at our data to see if it makes sense logically. For example, if we have the same child who is admitted to, who appears in the data to have been admitted to hospitals in different parts of the country at the same time, then this could indicate that something has gone wrong with the linkage. So there are lots of different ways that we can think about doing this. Which will depend on the type of data that we're looking at. So here we use simultaneous admissions, but we could think about where we have a death record followed by an admission record, or we could think about a logical combination, so prostate cancer records and female hospital records, for example. And although it might only show us the tip of the iceberg, we might only be able to identify a small number of false matches. The important thing, again, is thinking about whether these linkage errors occur more often in one particular group. And here we saw that they were more likely to happen in children who had been born preterm and in Asian ethnic groups. So what about solutions to linkage error? I think as long as we're using the types of routinely collected administrative data that we have access to at the moment, in which there's an element of human input into how identifiers are recorded, linkage error in some form will always be a problem. So how to handle these linkage errors is an ongoing area of research, but there are two sort of broad areas that we can think about. The first approach reframes the problem in a similar way to multiple imputation. So rather than saying we need to create one definitive linked data set that is the true representation of reality, what we're saying is that we want to be able to analyze the data in such a way that we get an answer that reflects the truth. So we don't have one definitive solution, one definitive linked data set, but we might have multiple data sets that have been imputed in different ways and that more realistically reflect the uncertainty associated with linkage. So this approach would require that some information about the certainty associated with each linked record is provided to researchers. In NHS Digital, for example, who use a deterministic linkage strategy, they often give researchers a match rank, which tells us which variables were matched upon for each record. So we can use that and convert it into basically a weight to tell us how likely it is that that record really was the true link, and where we have some uncertainty about which is the right record, that's where the imputation approach comes in. And another approach is to use quantitative bias analysis, where we estimate our linkage accuracy rates, which might be estimating false matches and mismatches within subgroups, using any of the methods that I've talked about. And then we use those estimates of the linkage quality to work out what the answer would have been in the presence of no linkage error. So if we know that we've missed 5% of matches, we can add those 5% back in to work out what our answer would have been. So this gives us a way of seeing how much linkage error would be needed to change the interpretation of our results, which can be quite helpful. So to summarise, hopefully I've demonstrated that linkage with administrative data is extremely valuable, and it can be more efficient than traditional follow-up. We can create cohorts entirely from linked administrative data to provide a much larger scale analysis than has previously been possible. And we can also use linkage to supplement primary data collection in trials or cohorts or surveys. Data quality and linkage errors can be challenging and can challenge the reliability of linked data for analysis. Probabilistic linkage methods can provide measures of certainty that we can incorporate into our analysis. But mechanisms for linkage errors can be complex, and we need to think quite carefully about how linkage errors might manifest in terms of bias in our final analysis. But there are methods for trying to handle linkage errors, and these should lead to more robust research. So I'd like to thank everybody who has worked with me on these studies, and also thank you very much to you for listening and for inviting me to present today.
Great, thank you very much, Katie. That was an excellent and really informative talk. Thank you very much.